Great pleasure and honor to have all you esteemed doctors over here. I, Valerie Mendes, General Manager Marketing, on behalf of Aristo Pharmaceuticals, extend a warm welcome to all distinguished dignitaries gathered here, and sincerely thank each one of you for taking out your valuable time and joining us for this esteemed scientific program, the Bridge Summit. Under the auspices of the Indo-Global Cardiodiabetes Academy, supported by Aristo, the makers of Empatrol, a brand of empagliflozin. Indeed, your presence here today is a testament of your commitment for advancing knowledge. And today, the 9th of May, is indeed a very momentous occasion. Not because of the change that you are witnessing here in Bengal, but I think it happens to be one of the most auspicious day as we celebrate the birth anniversary of Rabindranath Tagore, known world over for his contribution towards education, towards literature and philosophy. In fact, he is Asia's first Nobel laureate. And his core values today in the medical fraternity is very important as he emphasized compassion, dignity, and service to humanity. And this is central today, most vital in patient care and highly relevant to the medical fraternity. So yes, we have his photo here so that we venerate him. So after this, considering that it is a momentous occasion, an auspicious occasion, I would now like to say a brief words about Aristo Pharmaceuticals. Aristo has been in the service of the healing hand since the year 1971, completing 55 glorious years, relentlessly making quality healthcare accessible to all. With its state-of-the-art WHO GMP certified manufacturing facilities, we have carved our global footprints across 25 countries world over. And all India, among today, Aristo ranks as the top 5th company in terms of prescriptions, and it has the distinction of being one of the top 3 in its covered market. We have been able to achieve this feat just because of your unwavering and continued trust and support. So we really thank you, dear doctors. At Aristo, we also endeavor to disseminate latest and high-impact scientific updates so as to enhance in-clinic efficiency and support continued advancement of knowledge and skills. Today, we have gathered here for one of the finest scientific forum, the Bridge Summit, that is designed to connect scientific minds, encourage evidence-based discussion, and serve as a forum for exchange of clinical insights. And I'm sure you will agree with me that today, management of diabetes has evolved from being just the metabolic management to being the cardio-renal metabolic management. And so we have the title for today, Managing CKM Syndrome in T2DM. Of course, to strengthen the understanding, to provide an in-depth clinical insight, and to give us a deeper understanding of diabetes, we have brought in one of the international faculties. He is a global icon. He is known world over. He has influenced clinical guidelines. He has transformed the pathophysiology of diabetes. And he is a legend, a renowned endocrinologist. Let's welcome Professor Dr. Ralph DeFronzo. Thank you, sir.
You want me to stand up? The talk is over. I can go sit down.
Right, sir. So it's our pleasure and it's our honor. We welcome you as an esteemed international speaker. And yes, we have the great audience here. And now I would also like to take the privilege to introduce our moderator for today, Professor Soumitra Ghosh. A big clap for him. Senior academic physician with extensive expertise in internal medicine, diabetes, obesity, and lifestyle-related cardiometabolic disorders. He is the professor and head of Department of Medicine, Medical College, Kolkata. He is also the governing body member of the API and serves as the Vice President, All India Association for Advancing Research in Obesity. Let's give a big round of applause and welcome, sir. I request Mr. Debashish Basu to kindly felicitate our moderator for today, Professor Dr. Soumitra Mitra. Sir, kindly welcome on stage. Mr. Debashish. We are also presenting him the Gitanjali, which is it's a symbol. Tagore has written it, a lot of collection of poems. And yes, I now request our moderator to introduce the international speaker for today. But before that, I would also like to inform you that this will be webcasted to 3 centers across India: Chennai, Aurangabad, and Gorakhpur. And at these 3 centers, we have regional moderators over there. In fact, to highlight, at Chennai, we have Dr. M.C. Deepak, a leading diabetologist and consultant associated with Madhav Diabetes Center. Okay. Then at Aurangabad, we have the chairperson, Dr. Hemant Fatale. He's a leading endocrinologist and diabetologist with over 30 years of extensive clinical experience. We also have the moderator, Dr. Anil Gawali, a leading consultant and interventional cardiologist and diabetologist. And at Gorakhpur, we have the moderator, Dr. Isar Khan, a leading nephrologist and consultant at City Hospital and DM in nephrology. So these are the regional moderators that we are having. And I think it is said that a teacher plants the seeds of knowledge, sprinkles them with love, and nurtures their growth. So with these beautiful lines, I invite Professor Dr. Soumitra Ghosh to kindly take over the event, who would introduce our international speaker as well as conduct the proceedings for the day. Thank you.
Good evening, everyone. So all the doyens in the field of diabetes and this metabolic medicine are here in this beautiful evening. And this evening is special to everyone here, because this is a very important day to all of us who are here, because it is the birth centenary of the most renowned person across the globe, originating from Bengal, is Kavi Guru Rabindranath Thakur. So it is culturally very important evening to meet here. It is a very important politically in the nation, because the new government has taken the oath only today on this 25 Boishak, the 9th May. And it is a big change, welcome change in Bengal. So it is politically important day. But we are here because it is scientifically very important evening, because we have the living legend in the field of diabetes who has transformed these ideas, the management, these newer innovations, the discoveries, which has changed the current practice in diabetes care across the globe. And this transformative energy is here with us. So we are fortunate enough to have Professor Dr. Ralph A. DeFronzo. The name creates a sensation among all of us who practice metabolic medicine, who practice diabetes, any corner of the globe. Because this man single-handedly has changed every meaning, every implications of this diabetes management. It is not the blood sugar control, it is the organ protection, it is not the control, it is actually this modifying the disease, because knowing this pathophysiological basis of this disease. Professor DeFronzo is a professor of medicine, the chief of diabetes division, deputy director, Texas Diabetes Institute. He does not need any introduction in any place of the globe who manages diabetes across the globe. So I will just invite Professor Dr. Ralph A. DeFronzo, who is the father figure of modern diabetes management innovative discoveries. We all know there are 3 molecules which are the wonder molecules in this century. And the number 1 molecule is the SGLT2 inhibitors. Because the cardiologists think it is their own molecule, nephrologists think it is their own molecule, it is the endocrinologists who think it is their own molecule. It has changed this definition of management in every corner. And this person is the key, the father of these SGLT2 inhibitors, because of his innovations, these discoveries. He has given life to this molecule. He is the world leader who globally transformed the today's diabetes care. He is the highest winner of lifetime scientific awards given by ADA or ESD or whatever. 2008 ADA Banting lecture on this ominous octet changed everything. From that, we wanted to understand what is diabetes. Is it blood sugar only? Because that summarized the 45 years of transformative clinical investigation and described the whole body, all organs, cellular and the molecular etiology of type 2 diabetes mellitus. And it is not only the control of blood sugar, it is actually the disease modification, and by which we can manage diabetes care. So we should give a ovation, standing ovation to this person who is here with us. And we are really very happy and fortunate to have this living legend in the globe today, Professor DeFronzo. And just give a big applause as well. I will invite the people who have organized this program, who have taken all the pain to take him to us, to felicitate him.
I'll let you move in this, okay? And I'll get later. Okay. We need a picture here.
Now I will request the Professor DeFronzo to share his wisdom to all of us on this managing this cardiovascular, kidney and the metabolic syndrome, which is a very new concept in the Indian perspective, in Indian type 2 diabetes mellitus. Sir, please enlighten us.
Okay, I have to say that was the nicest invitation I've ever gotten in my life. So, for those of you who don't know my background, I actually am double boarded in endocrinology and nephrology, and I actually have also done a cardiology fellowship, although only 1 year of the cardiology fellowship, enough training. So it's a great pleasure to be here. I have many, many friends and recognize many people here in the audience. And we're going to talk about a medication and an approach to therapy that is really very dear to my heart, because the SGLT2 inhibitor class of drugs I actually invented when I was a renal fellow at a hospital of the University of Pennsylvania. So where does the story start? Story starts with fluorescein. So for many of you, you probably never heard of fluorescein before. The nephrologists in the audience probably do. But I was trained as a renal micropuncturist. I used to put little tiny pipettes into tubules of dog kidneys, and I was very interested in how insulin regulated sodium and glucose transport in the proximal tubule of the kidney. And I wanted to get hold of a medication or a drug that would block that transport. And going through the literature, I came across studies that actually dated back to 1898, started in Germany. And I learned about fluorescein. And fluorescein comes from the bark of the apple trees when the apple trees bloom in the spring. And it turns out, and I'll take you through this, fluorescein is a very, very powerful inhibitor of sodium and glucose transport in the proximal tubule. And when I was a renal fellow, it dawned on me, and the idea, I guess, is so simple, no one ever thought about it. I could just simply block this glucose transport in the kidney. You would excrete the glucose in the urine, the blood sugar level will come down, and we would cure diabetes. Well, the thought was a good one. We didn't cure diabetes, but we made an impact to treat diabetes. And the original articles were all published in the late 1980s, early 1990s. And why did it take so long? And the first drug that came to the market was dapagliflozin, 2012. Why did it take so long for the drug to get to the market when we did the studies in the 1990s? Because the nephrologist said, if you listen to Dr. DeFronzo, you will kill the kidneys. So if you put glucose in the urine, it will glycosylate the proteins and you'll get progressive renal disease. And actually, the nephrology community actually blocked the development of the drug for over 10 years. I tend to be a persistent guy, and with Bristol Myers Squibb and then AstraZeneca, we eventually brought dapagliflozin to the marketplace. And we did the original studies in rodents, and we looked at a number of diabetes models. And what we showed is that when you give fluorescein, as one would predict, you got a huge increase in glucose excretion in the urine. The blood sugar came down. And what happened is that in rodents, you actually can normalize the glucose concentration. In humans, we can do a good job at lowering the glucose, but we're going to need other medications. I'll take you through the ominous octet if we really want to normalize glycemia in people. And we also looked at the molecular and cellular mechanisms by which this benefit occurred. And what we noted was that in muscle, there was a major improvement in the insulin signaling transduction system and also an upregulation of the GLUT4 transporter, which is the major transporter that got glucose into cells. And we also showed a major improvement in beta cell function. And from these studies, we coined the term glucotoxicity. And the gist of this is that high glucose induces insulin resistance. High glucose induces beta cell failure. And if you can lower the glucose by whatever mechanism, here a drug that's working on the kidney on the SGLT2 transporter has no SGLT transporters in the beta cells or in the muscle, you could literally normalize glucose. So, of course, we wanted to know this sort of approach, would it work in humans? In rats, it was great. In mice, it was great. But you know, mice and men have one thing in common, the letter M. So we make all these discoveries in rodents, but ultimately what we would like to do is to take it to humans. And the very first study was done actually with dapagliflozin. And because this approach is so powerful, you don't need a large number of people. So you can see here we had 18 diabetics, and we randomized them 2-to-1 to dapagliflozin orange or placebo in yellow. And in the United States, it's virtually impossible to find lean type 2 diabetics, so not surprising. The BMI is 34. In my clinic, actually, now the BMI is closer to 37 to 38, and we'll talk maybe about the epidemic of obesity as we go through this. Starting A1C was 8.7. Now, everybody had an oral glucose tolerance test, and they had it at baseline, And then we treated them only for 14 days. So you'll see that the effect of these drugs are really very rapid in onset, not only for glucose, but you'll see many of the renal and cardiovascular problems that they attack. You see the effects literally within 14 to 28 days. So the fasting glucose fell by 30 milligram per deciliter. The major regulator, as I'll take you through this, of the fasting glucose is hepatic glucose production. So we knew that the drug was working on the liver. And then if you look at the rise in glucose after the meal, it fell from 330 to 264. It fell by about 70. 30 milligram per deciliter of that is the fasting glucose. So postprandial glucose fell by about 40 milligrams per deciliter. The postprandial glucose is primarily regulated by muscle glucose uptake. So we already knew that this drug was going to have an effect. In addition to having an effect on the beta cell, it was going to have an effect on both the liver and the muscle. Now, on a separate day, the patients came back, and we also did a euglycemic insulin clamp. That's a technique that I developed many, many years ago. This is the gold standard for measuring insulin sensitivity. And that's the two yellow bars in the middle. So we're going to raise the plasma insulin concentration by 100 microunits per ml. And then using radiolabeled glucose, we can quantitate the amount of glucose that's taken up and metabolized by all the tissues in the body. And as you can see here, there's about a 35% improvement in insulin sensitivity. But again, in muscle, where the glucose is being disposed of, there are no SGLT2 transporters. So this is an indirect effect by reversal of glucotoxicity. Now, they also, as I told you, they had an OGTT, and we measured the C-peptide response. And I'm not sure where's the best place to stand here. The C-peptide response doubled. So we knew that there was a major improvement in insulin secretion. And then the gold standard for measuring beta cell function is to look at how much insulin is coming out and relate that to how insulin resistant you are. So in you or I, if we become insulin resistant, say I treated you with steroids, you would become insulin resistant, your beta cell would read that and make more insulin. So the gold standard for measuring beta cell function is shown here in orange. This is called the disposition index, and it expresses the amount of C-peptide that comes out during the OGT, factored by how insulin resistant you were. And you can see that there's a doubling of your beta cell function. So just as we showed in the rodent studies, this approach here, dapagliflozin, as we showed with fluorescein, led to a major improvement in both beta cell function and insulin sensitivity. Now, we then went on to look at the other SGLT2 inhibitors, and tonight I'm going to talk to you about empagliflozin, and we basically saw exactly the same results. So at the top panel, we did an OGTT, and I'm going to look at how much C-peptide came out. And you can see in yellow, within 2 days, we have a major improvement in insulin secretion. And that effect lasted for 14 days. In fact, in long-term studies, this effect lasts for several years. And then in the middle, these are the data from that euglycemic insulin clamp. And again, within 2 days, there's about a 35% improvement in insulin sensitivity. Should be a little asterisk here, and it persists just as does the improvement in insulin secretion. And then this gold standard, insulin secretion per insulin resistance, index of beta cell function, again, within 2 days, a major improvement. So everything that we showed in the rodents was extrapolable to humans. And we got very similar data with dapagliflozin, as I showed you here with empagliflozin. So I think many of you here are familiar with my Banting lecture in 2008. And I titled it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So what was the triumvirate? In 1987, I got the Young Investigator Award by the ADA, and the triumvirate consisted of beta cells, and I'll take you through this, liver, and muscle. So every one of you went to sleep last night. Your fasting glucose is 80, 90 milligram per deciliter. You woke up in the morning, and your fasting glucose was still 80 or 90 milligram per deciliter. So how does that happen? You haven't eaten anything. So throughout the sleeping hours, your liver puts glucose into the systemic circulation at a constant rate. And that clamps your glucose at 80 and 90. That's critical because your brain can only utilize the glucose. You wake up in the morning, you go ahead and do your thing. So what goes wrong in people with diabetes? There's severe insulin resistance in the liver. The liver overproduces glucose throughout the sleeping hours, and this is the cause of fasting hyperglycemia. Now, the diabetic is then going to have their breakfast, their lunch, and their dinner. They may start with a high fasting glucose. Now there's an excessive rise in glucose above baseline. All of that carbohydrate, the glucose in the meal, needs to be taken up in the muscle. And because the muscle in the diabetic is insulin resistant, you get postprandial hyperglycemia. And then this insulin resistance stresses your beta cell. And there's also a genetic component of beta cell failure that goes with diabetes. And this was the triumvirate. So when I gave the Banting lecture in 2008, of course, we knew a lot more about the pathophysiology of the disease, and I simply titled it From the Triumvirate to the Ominous Octet. And then I'm going to take you through, if you understand the pathophysiology of a disease, you'll understand better how to treat it. And so what are the other 5 players? Let's start up here in the right, the fat cell. The fat cell is your friend initially, okay? You overeat, and what's driving the epidemic of diabetes, of course, is the epidemic of obesity. You take in those excess calories, and where do you put them? In the fat cell. And as long as they stay in the fat cell, you're okay. But what happens? You keep taking in excess calories, fat cells expand, become very resistant to insulin. And now the triglycerides within the fat cells start to get broken down. You release free fatty acids into the bloodstream. Probably no one in this room in your clinical practice has ever measured the plasma FFA level. But if you were to measure the plasma FFA level in an obese person or a diabetic, you would find that the FFA levels are very, very high. So what's the problem with elevated FFA? Elevated FFA causes insulin resistance in the liver, insulin resistance in the muscle, progressive beta cell failure. At the top is the gastrointestinal tract, okay? So when you eat a meal, you release 2 incretin hormones, GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulinotropic polypeptide, okay? Those 2 incretin hormones account for 70% of the insulin that you release during a meal. So what goes wrong at the level of the incretin axis? Is it you don't make enough GLP-1 and GIP? No, you make plenty of GLP-1 and GIP. The problem is your beta cells are severely resistant to the GLP-1 and the GIP. And we, of course, have a treatment for this. And people have gone wild in the last 5 years with these newer GLP-1. And now India has become it always was the capital, the copycat capital of oral agents. It's now the copycat capital of semaglutide and tirzepatide, Ozempic and Mounjaro. And these are the new blockbuster drugs that will reverse this defect. At the level of the alpha cell, Dr. Roger Unger, many, many years ago, showed your alpha cells hypersecrete glucagon. And that elevated glucagon levels actually drive hepatic glucose production. And this year, if any of you are at the American Diabetes Association, I'll be involved in a debate. Is glucagon good or bad? Well, for diabetics, it's very bad. But if you were to combine it with the GLP-1 receptor agonist, it turns out to be very good, very paradoxical. I may get this question afterwards. I'll try to answer it for you. If you're at the American Diabetes Association this year, you'll hear more about it. And then we're going to talk a lot about the kidney. That transporter in the kidney, the SGLT2 transporter, the S stands for sodium, the GL for glucose, the T for transporter. And that transporter we showed in kidney biopsies from diabetic patients is markedly upregulated. So the diabetic has an elevated glucose, filters more glucose, but what happens? Does that glucose end up in the urine? No, because there's an upregulation of the SGLT2 transporter. So even though you filter more glucose, it doesn't end up in the urine. You reabsorb it. And that's playing a major role in the development of hyperglycemia. And of course, we're going to intervene with the SGLT2 transporter to block that glucose transport. And then what's driving the epidemic of diabetes? It's the epidemic of obesity, okay? And that all has to do with the regulation of food intake in the brain, okay? And in the hedonic areas of the brain, there's a loss of gray matter and the disruption of the normal circuitry. So when you look at food, particularly food that's very palatable, it looks very good to you, and you overeat. Obesity is a food addictive disease, okay? It is no different from alcohol addiction. And if you think so, you're absolutely incorrect. It's no different from drug addiction. And the same areas in the brain that are associated with food addiction are associated with alcohol and drug addiction. The GLP-1 receptor agonists work in these hedonic areas in the brain to correct the disrupted neurocircuitry, and they're very good at shutting off your appetite and promoting weight loss. So if you now think about this, if we have 8 problems, you're not going to control diabetes with one drug. So the American Diabetes Association, I love the American Diabetes Association, but they're always 10 to 15 years behind. And we've had phenomenal drugs that work on the heart, that work on the kidney, that work on the liver. But the American Diabetes Association, until recently, in fact, until last year, has never recommended combination therapy, despite all of the wonderful drugs that we have. And I've been a strong proponent for at least 15 years of using drugs together. So one of the nice things about the kidney is I told you we have a variety of medications. We're going to talk about epagliflozin specifically, but there are a number of drugs in this category that work on the kidney to put glucose out in the urine. And as I showed you, as the blood sugar level goes down and I reverse glucotoxicity, I improve insulin secretion, I improve insulin sensitivity in the muscle. So I'm correcting 3 of the problems that are present in our diabetic patients. So this is going to be a very good drug to use in combination with any other of the oral or injectable anti-diabetic agents that you want to use. It works on the kidney. None of the other drugs work on the kidney in terms of glucose control. So you can add it and expect to get an additive effect. And I will take you through all the clinical data that supports what I just said. Now, how do the SGLT inhibitors work at the level of the kidney? Everybody in your medical school, I'm sure, learned how the kidney handled glucose. I'm also sure that the day you graduated, you totally forgot it because you thought it wasn't important. So I'm going to bring this back to your memory bank. So the normal glomerular filtration rate is about 180 liters per day. The mean glucose during the day is 100. So you're going to filter about 180 grams of glucose every day. How much ends up in the urine? You see down here in the bottom right in pink, no glucose in URI ends up in the urine. So how does this happen? So there's a transporter, SGLT, sodium glucose transporter 2, in the early proximal tubule. It takes back 90% of the glucose. And if it does its job, the SGLT transporter will take back the remaining 10% and no glucose will appear in the urine. So many years ago, we know that diabetics are filtering more glucose. And when you look at what comes out in the urine, there basically was none there. Now, as I look around in the audience, I'm much older than most of the people here. But when I was an intern, we used to measure the urine glucose, and then we would give insulin based on the urine glucose. Do you understand how barbaric that was? Because the diabetics had very high glucoses. They were filtering a lot of glucose, but none of the glucose ended up in the urine. And that's why in the old days with insulin therapy, we never got diabetic patients controlled. Now, I started back in 1975. Some of you people I can see in the audience probably weren't even born in 1975. So in the old days, this was pretty barbaric. Now we know that you can't, of course, rely on the urine glucose to tell you anything about the plasma glucose concentration. Now we can measure the glucose so people can do CGM. We have much better techniques. So as I told you, this transporter in people with type 2 diabetes is markedly upregulated. And there's now another concept that I have to introduce you, and this is the concept of the renal threshold at which glucose spills into the urine. So I plotted for you here on the y-axis urine glucose excretion, and then the plasma glucose concentration on the x-axis. So I'm going to plug in an IV, and we've done this with both empagliflozin and dapagliflozin and canagliflozin. So everything that I'm going to tell you really pertains to this SGLT2 inhibitor, and the drugs are going to do very similar things. So as I infuse glucose and I raise your glucose from 80, 90 up to 180, no glucose appears in the urine. But once I get to 180, this is the threshold at which glucose appears in the urine. And now above this, as I continue to raise the glucose, all the glucose gets excreted. And this is you and I with the hemoglobin A1C of 5. Now, what about a person with type 2 diabetes? And these are all real life data from this paper in Diabetes Care. So here now, this is a person who has a hemoglobin A1C of 6.5. This is the level at which we make the diagnosis of diabetes. Well, you can see that this renal threshold is no longer 180, it's increased to 205. Now, what about a diabetic who has an A1C of 7.5? These are real life data in real people. A1C, the threshold is now 220 and so forth. And so when you have very high A1C, in which you would expect a lot of glucose to be dumped out in the urine, very little glucose ends up in the urine because that threshold is markedly increased. So now what happens if I put you on empagliflozin? Am I going to take you from this elevated threshold down to a normal threshold, 180? Will I take you lower? Well, these actually, again, are real data with empagliflozin. And I've taken an example of a person who is a diabetic, has a threshold that is increased to 220. Do I bring you to 180? No. Where do I bring you? 100? Nope. I bring you to a threshold of 40. Now, what are the implications of this? So when we published this, this really shocked people, okay? Because no one expected this kind of result. That means that in every single person in this room, if you have a fasting glucose of 80 and I give you empagliflozin, over the next 24 hours, you're going to dump 60 or 80 grams of glucose in the urine. Why? Because even though your fasting glucose is 80, I dropped the renal threshold to 40. So there is no such thing as a non-responder to one of these drugs as long as you have relatively normal kidney function. So now, when we saw this, we asked, well, look, if I drop the threshold to 40, why doesn't every person become hypoglycemic? So what we discovered was a whole new physiologic mechanism because hypoglycemia doesn't happen, okay? So even though I dropped the threshold of 40, your glucose never drops below 80. And the reason for that is the kidney generates a signal, and by the renal nerves, it sends that signal to the liver, and the liver makes an amount of glucose which is identical to the amount of glucose that's coming out in the urine. This is one of the most finely tuned physiologic mechanisms in the human body. So the conclusion of this is, look, if you're a cardiologist, look at this as a cardiology drug. Forget about the fact that we use it to treat diabetics. If you're a nephrologist, look at this as a nephrology drug. And I'll show you why I'm saying that, because these drugs have powerful effects to protect your kidney and your heart. If you're an internal medicine primary care doctor, it's your drug. If you're an endocrinologist, it's your drug. You do not have to worry about hypoglycemia, okay? So that's one of the major benefits of this class of drugs. So what about clinical studies? Where does empagliflozin fit in the armamentarium in terms of treating our diabetic patients, okay? So in the next 4 or 5 slides, they're set up in a very similar way. So I can use the drug as monotherapy. You're being treated with lifestyle, and then I just can add the empagliflozin. I can add it to metformin. If you're on metformin SUs, which is very commonly used therapy in our patients, I can add it to pioglitazone or insulin. And empagliflozin comes in 2 doses, 10 and 25. So this is the light orange and red. And the placebo is in yellow. And you can see you get about a 0.9 drop in A1C if your starting A1C is about 8. So if your starting A1C is 8 and I drop you 0.9 to 1, your A1C is now down to 7. That's the treatment goal that the American Diabetes Association advocates. The DeFronzo goal is better than the ADA goal. It's to get you less than 6.5, okay? So you can see that whatever the background medication is, this drug is going to give you a very, very nice glucose lowering response, okay? Now, what about body weight? You dump glucose in the urine, that's calories. And so at the end of 6 months, you're going to get about a 2.5 to 3 kilogram decrease in body weight. And again, it doesn't make any difference if we use it as monotherapy or if we're adding on to metformin, SU. Now remember, pioglitazone, which is one of my favorite drugs, we may talk about this later, it tends to make you gain weight, but when I add the empagliflozin, you actually lose weight. Insulin makes you gain weight. When I add the empagliflozin, I promote weight loss. So of course, I'm treating the obesity, and when I get you to lose weight, I'm going to improve insulin sensitivity. So this is an added benefit of the empagliflozin. What about systolic blood pressure? This is a sodium glucose transporter inhibitor. So I'm not only blocking glucose, I'm blocking sodium. So I put you into about a liter of normal saline negative balance. So over the next 48 hours when I treat you, you'll go into negative sodium balance by about 125 to 100 milliequivalents. You'll go into negative water balance. And when you do that, you're going to get a nice drop in blood pressure. And again, it doesn't make any difference which drug, which background you're adding it to. Systolic drops about 4 or 5. The other beauty of this is the higher the blood pressure, the greater the drop. So if you have a systolic blood pressure 150, you'll get about a 10 to 12 millimeter drop. These are in people who are normotensive. Now, what about comparison with other drugs that are commonly used in the treatment of our diabetic patients? So I also was the major medical advisor for Boehringer Ingelheim, and this is a summary of what you can expect in terms of A1C drop with empagliflozin, sitagliptin, and glimepiride. So I think everybody knows that the higher the A1C, so here's the A1C of 11 versus 6, the greater the drop in the A1C. And sitagliptin, the DPP-4 inhibitor, is very similar to glimepiride. And if you were to look at empagliflozin, whether it's the 10 or the 25 milligram, clearly more effective in lowering the A1C than any of those other 2 drugs. And moreover, you can use the empagliflozin in combination with these drugs if you would like to do that. So I know that DPP-4 inhibitors have been widely used and are widely used here in India and throughout the world. And so this is a study that we carried out about 8 years ago in people with type 2 diabetes who were placed on a placebo run-in to make sure that they were going to be compliant with taking the study medication. And then they're going to be randomized to linagliptin or to empagliflozin, one of the 2 doses, or the combination therapy for 52 weeks. So linagliptin drops your A1C by about 0.51. As I already showed you, the SGLT2 inhibitors are more powerful. So with both doses, the 10 and the 25 milligram, you get a greater drop, about 1. And when you put the 2 together, you get an additive effect. You never see a completely additive effect with the drugs, but you also always get a partially additive effect. So if you happen to be an advocate of DPP-4 inhibitors, then you can add it to the DPP-4 inhibitor. Now with the newer onset of the GLP-1 receptor agonist, if you can afford them, these drugs have replaced in large part the DPP-4 inhibitors. But just to give you an idea, Mounjaro, which is tirzepatide in Ozempic, cost $1,000 per month in the United States. So obviously for many people, they're not going to be able to afford the GLP-1 receptor agonists. So although they're great drugs, they were originally developed because they had their primary effect on the beta cell. We've kind of lost track of that because they promote so much weight loss. Everybody's talking about, I want to look like when I was 18 years of age and I was a soccer player. But the fact is, these drugs will get you to look like when you're 18 years of age if you have $1,000 per month and you're willing to take them for the rest of your life. Because as soon as you stop taking them, you regain all of the weight. So maybe we'll get some questions about how you can interact. I like this combination of GLP-1 with SGLT2. It's part of my triple first-line therapy. The third drug in my triple first-line therapy is pioglitazone. So all of my patients from day one are going to get a GLP-1 receptor agonist, whichever one the insurance will cover, and many of the insurance companies won't. They get an SGLT2 inhibitor and they get pioglitazone as well. And this just shows you the time course of action, but focus on the two yellow lines. These are the two the EMPA lines. You can see within 4 weeks, look at the nice drop, almost about 1% in A1C. And these studies were carried out for actually 2 years. And you see the A1C stays down. And of course, the combination therapy does better than the linagliptin, which is the weakest of the ones, or the EMPA alone. So you can very nicely combine the empagliflozin with the DPP-4 inhibitor, okay? Now, if I can make that go back, yeah. So here's the body weight change. Linagliptin is really neutral. It doesn't really have any effect on your appetite. You can see here about 3 kilos of weight loss with the empagliflozin. And when you put the two together, basically you get the equivalent of empagliflozin. The Lina is not giving you any additional benefit in terms of weight loss. But as I showed you in the previous slide, it does in terms of A1C. So what about triple therapy? This actually, triple therapy was first developed here in India, and the drug that you have here is Trijardi. We actually don't have triple therapy. It's interesting in the United States because the American Diabetes Association really until recently hasn't advocated combination therapy. Combination therapy is not very popular in the US. So this study was designed to take people who are on metformin and who are not doing very well, and then to treat them by adding a combination tablet of linagliptin and empagliflozin. So here now, the people are poorly controlled on metformin. I can add empagliflozin, and I get some drop in A1C. I can add linagliptin, I get a little bit more drop, or I can take the metformin away and then give them the Trijardi. So the Trijardi is metformin, it's empagliflozin, and linagliptin. And what you see is that you get a drop of about 1.2%. So you have the combination tablets here. You've had them long before we had them in the US, and I'm a big advocate of this. Now, in developing these SGLT2 inhibitors, since I am double boarded and had a background in nephrology, I predicted that these drugs actually would be renal protective. And as I told you, the reason why it took so long for these drugs to get to the market, because the nephrologists in the world did not believe that they would be effective. In fact, they thought that because you glycosylate proteins in the urine with the glucose, it would cause renal damage. But I actually predicted that they would work and exactly how they would work, okay? And I'm going to show you that in a second. What I never expected is the cardiovascular benefit. None of us expected that, and I'll take you through that in a second, okay? So, what do we know about these drugs? We know that they correct this novel pathophysiologic defect in the kidney. the SGLT2 transporter is upregulated. I'm going to block that. And when I block that, glucose comes out in the urine, and I get a nice drop in the A1C. Now, because you lose glucose in the urine, you're losing calories, okay? You're going to get weight loss, which is beneficial for our patients. You lose sodium in excess water in the urine. That's going to be very good in terms of lowering blood pressure. And because the drug works on the kidney, different from all other drugs, you can combine it with any of the other oral or injectable agents and no hypoglycemia. So you're going to get cardiovascular, you're going to get glycemic benefit, but then we're also correcting some of the cardiovascular risk factors. You also may get cardiovascular benefit. So empagliflozin was the first drug that unequivocally showed, and I'm going to show you the EMPA-REG outcome study, that this drug had a very powerful effect to give you cardiovascular protection. And when this study was presented at the American Diabetes Association, there were about 15,000 people in the audience, and everybody stood up and clapped because the results, as I'm going to take you through, were truly incredible. So these are people to get into the EMPA-REG outcome study. You had to have a previous cardiovascular event, okay? Could be an MI, could be stroke, could be peripheral vascular disease, but clearly you had already had a cardiovascular event. And now I'm going to randomize you to placebo, which is shown in the yellow curve, or to the empagliflozin, which is shown in the red curve. Now, in the United States, in order to get a drug approved for a cardiovascular indication, you have to show a benefit on the MACE endpoint. MACE stands for Major Adverse Cardiovascular Events. And there are three. That's non-fatal MI, non-fatal stroke, cardiovascular death. You have to show a benefit, okay? And so to the left now is the MACE endpoint. This is a Kaplan-Meier plot, and you can see here, if you, from the back of the room, you may not be able to see this, but within 1 month, these curves separate. And they separate statistically significantly within 1 month. This is incredible, okay? That you're getting cardiovascular protection literally within 1 to 2 months, okay? And the hazard ratio is 0.86. That means there was a 14% risk reduction in the combined endpoint of non-fatal MI, non-fatal stroke, and cardiovascular death. But what really took everybody breath away was what's shown here in the middle, okay? This is the effect of empagliflozin on cardiovascular death, okay? Hazard ratio is 0.62. There was a 38% reduction in death. That's incredible. We never seen anything like that before. And then in the far curve here to the right, this is hospitalization for heart failure, 35% reduction. And quite frankly, nobody expected this. We knew that it would control glucose. I projected that it would, and I'll take you through the kidney data, that it would work in protecting your kidney. But this came as a surprise. And this effect now is so rapid in the United States. If you're admitted with heart failure, you are started on the drug before you leave the hospital. We don't give the people a prescription and send them home anymore. You get the drug and the prescription is filled before you leave the hospital because these effects are so rapid. Now, what about heart failure? So this is the Emperor Reduced It study. So this is heart failure with reduced ejection fraction. This is usually secondary to ischemic disease. And you can see, again, placebo in yellow, the empagliflozin is the orange curve, lies below, and the hazard ratio is 0.75, means there's a 25% decrease in hospitalization for heart failure in people who have reduced ejection fraction. Now, in people who have type 2 diabetes, heart failure with preserved ejection fraction is much more common. And hospitalization with preserved ejection fraction, this is a disease not so much of the arteries, but of the myocytes. In my opinion, the major mechanism is we're mobilizing, I'll show you some of the other mechanisms. We're mobilizing fat out of the myocardium, and we're also changing substrate metabolism in the myocardium as well. But in people with heart failure with preserved ejection fraction, the empagliflozin hazard ratio 0.79, 21% reduction in heart failure. So whether you've had cardiovascular disease in terms of MI or cardiovascular disease because of heart failure, the empagliflozin and the other SGLT2 inhibitors are also fantastic at treating these. Now, in the EMPEROR reduced, they also look at renal function. And so this is over 124 weeks. We're looking at the change from baseline in glomerular filtration rate. So in the placebo group, you can see there's a progressive decline in the glomerular filtration rate. In the people treated with empagliflozin, there's an initial, a little drop in the GFR, and I'm going to take you through in a few moments why this happens. But then this stabilizes, and this curve is relatively flat. And within 52 to 72 weeks, the curves cross, and now you can see you're getting renal protection as well. I'm going to show you in a few seconds the actual renal study per se. So now I've had a big interest in how these drugs work on the myocardium. And I have 2 grants from the NIH. One is to look at heart failure with reduced ejection fraction, and one to look at heart failure with preserved ejection fraction. Our beloved president is destroying the NIH, by the way. Hopefully your new president won't do the same thing here in India. But when I started my career in 1975, the National Institutes of Health funded 48% of all grants submitted, okay? Until Mr. Trump took over, the cut line was 16%. Now the cut line for funded grants in the United States by the National Institutes of Health is at the 5 percentile level. And this is a total disaster for science as we go forward. So how do these drugs work on the heart? I believe that the major mechanism, or at least half of the major mechanism, is hemodynamic benefit. So these drugs, as I said, they decrease the blood pressure, okay? So they're markedly decreasing afterload. And in addition, I put you in a negative salt and water balance. I decrease the preload. So I'm doing 2 very good things from the heart. It doesn't have to pump against the high pressure, and I decrease the preload. Now, normally when you drop the blood pressure and you drop the intravascular volume, what happens to heart rate? It goes up. In no study did we ever see an increase in heart rate, suggesting there was a big effect to inhibit the sympathetic nervous system. And in fact, we've actually shown using norepinephrine turnover that this is indeed correct. Now, in addition, these drugs have a very powerful effect to decrease arterial stiffness. And you can show this within 2 weeks that in the aorta, so I measure your blood pressure here, it goes down by 4 or 5. I measure it in the aorta, it goes down by 8 to 10. Okay, so it would, and this is a very acute effect. So this is a huge afterload reducer. And as I said, using norepinephrine turnover, tritiated norepinephrine, it inhibits sympathetic nervous system activity. And of course, if I get these benefits without increasing heart rate, that's a big benefit for the heart. The other major mechanism I believe is related to ketones, okay? So when I put you on the drug and you now start to put the glucose out in the urine, your blood sugar level drops. Now, all of a sudden, the cells in the body are acutely deprived of their major fuel, glucose. So what happens? You stimulate lipolysis, okay? So you release FFA into the bloodstream, and the free fatty acids are carried to the liver, and by beta oxidation, you chop off 2 carbon compounds at a time, and you end up with ketones. It turns out that ketones are the preferred fuel for the myocardium. Ketones are more avidly taken up by glucose, and when you burn ketones, you generate more ATP per oxygen consumption, which is very beneficial for the myocardium. And this now is going to have a huge protective effect as well. And we've done the studies where you can take people with diabetes and you can give them dose response elevation in the ketone levels. And you can show within 2 hours that physiologic doses rises in ketones markedly improve cardiac contractility. Now, I don't have time to take you through the rest of the story, but these drugs are actually very good in improving insulin resistance. Your myocardium, if you're a diabetic, is severely resistant to insulin. These drugs promote weight loss. They decrease total body fat. They also help mobilize fat out of the myocardium, another potential protective mechanism. I'm not a big believer in the uric acid story, but these drugs block sodium and uric acid are co-transported in the proximal tubule, so I lower the uric acid. They have very powerful effect on the angiotensin 1-7 system. This is the cardioprotective angiotensin system, okay? And you see benefit here. They decrease inflammation, oxidative stress, and they inhibit a number of sodium pumps that potentially could improve myocardial function. So many potential mechanisms. You'll see a lot more to come about what I've just taken you through. Now, let's turn to the kidney, because we're now in this cardiorenal metabolic era. And every Friday, I actually spend my Friday in the clinic. We've established the cardiorenal metabolic clinic. So we have a nephrologist, we have a cardiologist, we have an endocrinologist, and then we have Dr. DeFronzo, who does all three. So we're big believers in the cardio. Actually, I like cardiorenal metabolic better than cardio kidney metabolic, but American Heart and ADA has adopted CKM. I like CRM. Whichever you like, doesn't make any difference. These drugs have very powerful effects on the kidney. So this is the study with empagliflozin, chronic kidney disease. You see, it's a very big study, 6,600 individuals. And what's important for you to recognize, in this study, there were type 1 patients, type 2 patients combined. In the United States, these drugs are not approved for the treatment of type 1 diabetes because they can cause euglycemic diabetic ketoacidosis. But if you have renal disease, you actually can use the drugs because there were type 1 diabetics in this big kidney study. Now, you had to have either a low GFR or moderately reduced GFR with proteinuria. About 20% of people with type 2 diabetes will get renal disease, a reduction in the GFR without proteinuria, okay? So in your diabetic patients, annually, you should be getting a urine albumin to creatinine ratio and an eGFR. And what I can tell you is that in this study, the people who had a low GFR without proteinuria, they benefited as well as the people who had heavy proteinuria. And the primary endpoint was a combination of having your GFR, doubling your serum creatinine, progressing to end-stage renal disease. That meant dialysis or transplantation or renal death. And again, you can see these curves take a little bit longer to separate. It takes about a year. The cardiovascular benefit you see much more quickly, but over the course of 2.5 years, you see the hazard ratio is 0.72, 28% reduction, and that combined cardiovascular renal endpoint. Now, if we look at the individual components of the primary endpoint was renal and cardiovascular, hazard ratio 0.72. Progression of kidney disease, 7.2. End-stage kidney disease, meaning you don't go on dialysis or transplantation, 7.5. Cardiovascular death, heart failure, all benefiting in this study. So very powerful drug. Good at lowering glucose, good at protecting your kidney, good at protecting your heart, okay? Now, how does this class of drugs work? I'm going to talk you through it, but you can either listen to me or you can look at the slide. And I projected that this exactly would happen in 1988, based on the Barry Brenner hypothesis. So Dr. Brenner is a very famous nephrologist, and the major kidney book is the Brenner textbook, okay? And based on the Brenner hypothesis of kidney disease, I projected that these drugs would save your kidney. Last month at the American Society of Nephrology, I gave the Barry Brenner Memorial Lecture in recognition of inventing the SGLT2 inhibitor class of drugs. So it took 36 years to be recognized, which is a problem. If you have an idea before the rest of the world, you're usually an idiot. And then 20 years later, everybody says, oh, yes, we knew this all along. And they assume that it's their idea, okay? So this is an old story. So if you're a diabetic, whether you're type 1 or type 2, you're hyperglycemic. Now, what does that mean? That means you're going to filter more glucose. More glucose in the proximal tubule, you're going to reabsorb more glucose. And with that glucose, you're going to reabsorb sodium. So that means less sodium is going to go down to the juxtaglomerular apparatus. So the kidney looks at itself as being underperfused. So it's going to generate two signals. It's going to send one signal to the little arteriole coming into the kidney, the afferent arteriole, and it's going to say vasodilate. I'm going to put more blood flow into the kidney because I think I'm being underperfused. That's going to increase your GFR, but it's also going to increase the interglomerular pressure. It's going to generate a second signal, and the second signal is going to go to the efferent arteriole, and it's going to say vasoconstrict. And that's also going to increase the GFR. So this leads what we call hyperfiltering and renal hypertrophy. But the real problem on a long-term basis is all of this is happening because in each glomerulus, there's an increase in intraglomerular pressure, and that's going to damage the kidney. So this is shown figuratively here. So here's the afferent arteriole coming in. It breaks up into the glomerular tuft, and then here's the afferent arteriole coming out. So in type 1 diabetic patients, what does epagliflozin do? It inhibits adenosine. Adenosine is a vasoconstrictor, okay? If I inhibit that, you vasodilate. And that's where in type 1s, the SGLT2 inhibitor works. In the efferent arteriole, it increases angiotensin 2 and angiotensin 2 sensitivity, vasoconstriction. In type 2s, okay, it's a little bit different picture, okay? In type 2s, the SGLT2 inhibitor really doesn't work on the afferent arteriole. What we've shown is it works here on the efferent arteriole to vasodilate. It doesn't make any difference which way it's working. You're going to decrease intraglomerular pressure, and that's going to save your kidney. Now, this is paper is published in Nature Nephrology, but I took you through the ominous octet for glucose, okay, and the pathophysiology. There's an ominous octet for the kidney as well, okay? So we've talked about deranged tubuloglomerular feedback, okay? This increase in intraglomerular pressure. When you develop chronic kidney disease, we give you all kinds of drugs. We pay a lot of attention to you. But if you really want to stop kidney disease, just control the glucose. Prevention is the best thing that you can do. But what happens is that we don't do it. Sometimes the doc's not aggressive enough. Sometimes the patients don't listen to us. And then some of these drugs are expensive. So lots of impediments. We know that hyperglycemia is a bad actor. And if you keep the glucose in the normal range, you're not going to develop kidney disease. Next most important thing that you can do is control the blood pressure, okay? So high blood pressure is very destructive to the diabetic kidney. So what is a normal blood pressure now considered in a diabetic patient? It's 120/80. It's not 130/85 or 190/85. By all guidelines now, it's 120/80. And believe me, that's not so easy to achieve in many of these people who have refractory hypertension. Hypoxia. You're reabsorbing all of that glucose and sodium in the proximal tubule. Sodium has to be then transported out of the proximal tubule. That's very, very energy requiring. So the kidney in the proximal tubule, using bold MRI, we and other people have shown, is hypoxic. This leads to inflammation, fibrosis. This is glomerular damage. Podocyte dropout. The podocytes are the cells that sit on the glomerular basement membrane, and with the foot processes, prevent albumin from sneaking into the glomeruli. Hyperglycemia and insulin resistance damage the podocytes. Albumin now gets into the glomerular tuft. It causes glomerular sclerosis and mesangial hypertrophy. One thing that's commonly overlooked is obesity. I believe that at least half of what people attribute to diabetic kidney disease is not the glucose, it's the fat that's in the kidney. And we have a large NIH grant to actually look at lipotoxicity in the kidney. Your tubules actually are the first part of the kidney that start to hypertrophy in diabetes, long before you see the glomerular hypertrophy. And when the tubules hypertrophy, they also release growth factors. But what do the growth factors do? They then send a signal to the glomerulus to hypertrophy. The pressure within the glomerulus is proportional to the radius. So these tubular growth factors, by increasing the pressure, contribute to the kidney disease. And then lastly, are genetics. If you choose your parents unwisely, you're screwed. You can't go back and choose your parents again, okay? So before you're born, you should have checked out who your parents are. If they have diabetes, probably you should have got new parents. If they have diabetes with kidney disease, you definitely should have got new parents, okay? So there clearly is a strong genetic background here, and we haven't identified the genes at play at risk. Now, look at all the stars up there. This is the SGLT2 inhibitor. That's the ominous octet. It's correcting 7 of the problems. It's a phenomenal drug for protecting your kidney. So there's an ominous octet for the kidney. We correct 3 of the problems. In the heart, well, I showed you, there are 20 problems at the level of the heart. We correct 3 of the problems. For glucose, we correct 3 of the problems. Going to be a very good drug. Now, we've also have a big interest in MASH and MASL. I wish these GI people would stop changing the name. You know, it used to be NASH, and every 6 months they have a new name for the disease, okay? But now we call it MASH, okay? And what we've shown, and I'll take these data are just recently published, these drugs actually have a quite significant effect to decrease liver fat. So this is the EMPA-REG study, where they looked at ALT. I can show you the same data for AST. But empagliflozin significantly decreases the ALT. And if we divide these people in the study with the highest ALT to the lowest, you can see the people with the highest ALTs get the greatest reduction, okay? And we actually have now done a big study. It's published in Diabetes Care not too long ago, where we took people and we measured their liver fat by MRI PDFF. And you can see here in the diabetics who have increased fat in the liver, empagliflozin decreased liver fat content by 3%, which is quite significant. In the non-diabetic people with MASH, we saw also a decrease in liver fat content. And if you look at the change in liver fat, it's strongly related to the change in body weight. So as you're losing weight, you are mobilizing fat out of all organs in the body. I already told you, get it out of your heart, you improve HFpEF, okay? You get it out of the muscle, you improve insulin sensitivity. You get the fat out of your beta cells, you improve insulin secretion. You get the fat out of the liver, you improve the MASH. And it's closely inversely related to the improvement in insulin sensitivity. So this is a review article by Dr. Gastadelli, who has been with me for a long time. She's now back in Italy. So here are all the SGLT2 inhibitors, and every one of them decreases liver fat content, very similar to what I just showed you. And if you look at fibrosis markers, where they've been looked at, they decrease. And if you look at hepatic enzymes, they all decrease. So we now recognize in the United States, MASH, liver fat, okay, has now surpassed alcohol as the leading cause of liver transplantation. So this has become a big problem. And here's a drug. Who would have ever thought this was going to happen? Okay. So we predicted kidney, we predicted glucose benefit, heart we didn't predict, and we didn't predict the liver benefit. The benefit is due to the fact you're losing weight and you're mobilizing fat out of the liver, a big improvement in insulin sensitivity, and an increase in fat oxidation in the kidney. So in summary, what do we know about empagliflozin? It's very good at lowering your A1C. It improves beta cell function. It improves and ameliorates the insulin resistance. You lose a modest amount of weight. It reduces your blood pressure. It's good for protecting your heart. It's good for heart failure. It protects your kidney. We think that there's benefit now in MASH and MAFLD. And even though this study hasn't been done, I guarantee you, if someone would look, if there are any ophthalmologists here and you're looking for a study to do, I think it would protect your eyes. This drug is very safe. The only thing you have to worry about is in women, there's a small increase in vaginal mycotic infections. Uncircumcised males, also a small increase in penile mycotic infections. Cleanliness and drying yourself after you go to the bathroom is critically important. Other than this, the side effects really are quite minimal, okay? So in summarizing, EPA has proven glycemic efficacy. It's good in protecting your heart. In terms of MI, it's good in protecting your heart for heart failure. It is good for slowing chronic kidney disease. And to end, it is an incredibly good drug. And as we go forward, we're still learning new things. Like, who would have thought we're going to see this protection at the level of the liver? In my opinion, it should be first-line therapy. I've already said this. It's a drug that should be used by endocrinologists, cardiologists, nephrologists. It's not going to cause hypoglycemia. Of course, if you're using with insulin or sulfonyl ureas, you can get hypoglycemic, but the drug itself is not going to cause hypoglycemia. This is going to be my last slide. Finally, the American Diabetes Association, it's taken them a decade to change. We've had all these cardiovascular and renal studies for 10 to 12 years, okay? But it wasn't until 2024 that the American Diabetes Association changed their guideline, and they still don't have it right, okay? So first-line therapy, what used to be here? Metformin. I like metformin. I single-handedly brought metformin to the United States in 1995, New England Journal of Medicine article. But I don't use metformin as first-line therapy anymore, okay? So this is what the ADA says. If you have atherosclerotic cardiovascular disease, you can pick SGLT2 or GLP-1, or more importantly, you should have them on both. If you have heart failure, SGLT2, this needs to be revised. We also know the GLP-1s work here. And if you have renal disease, they say SGLT2, this needs to be revised. You should have GLP-1 here. So everything here is correct. But again, the ADA is always 5 to 10 years behind what we know. So that's the last slide. I'm going to stop here, and I think we have time to bring our moderator back up and ask questions from the audience or people who are listening in.
Horse's mouth, who has developed the molecule, the wonder drug of the century, and we are lucky enough to interact with him and directly listening from the father of this SGLT2 inhibitor. And we have learned all these things. It is really amazing to see that 33 years, 45 years he took to just publish the research. Innovations, the discoveries, the changing practice in diabetes care across the globe. So give a big hand for the father of this SGLT2 who has changed this practice of diabetes. We will take up the questions after the second session. We have a panel discussion on this CKM, on this, which is the talk of this, of this decade rather, because it is not a single organ which has to be focused. It is the, sir, please take a seat and.
Yep, I'm going to get a glass.
So now in this evening, we will discuss a small panel discussion, and as it is discussed this evening is CKM, we will call upon the stage this Captain C, the cardiologist, Professor Soumitra Kumar, who does not need any introduction. He is the professor of this RKM and this VIMS. He is a very well-known face of this city and the country as well. Now I will call Professor, this Captain K, this kidney, this renal, part, this Dr. Jayanto Dotto, very well-known, nephrologist and the transplant physician of the city, very well-known to everyone. Now, this last but not the least, the Captain M, this metabolic physician, the endocrinologist of our city, very well known. Professor
Yeah.
Dev Malyo Shanal is the professor of, endocrinology in the KPC Medical College. So I will request this team to please felicitate all these, three panelists here. Captain C, Captain K, and Captain M, please. Professor Soumitra Kumar, please. Captain K, Dr. Jayanto Dotto. Captain M, the metabolic physician, Professor Dev Malyo Shanal. So you can all ask the questions. We have these national faculties as well, because this program is being transmitted across the nation. There are many panelists and the moderators in other cities, like in Mumbai, like in this Aurangabad, like in Delhi. And we'll have a very short session, because after we have listened from this horse's mouth, we have very small part, but whether we have understood well. So we will go through a very, quick session. Please, can I have the slides?
I have a place for it in my life.
So I will come to Professor Demalyo Shanal. So we are actually discussing about this metabolic syndrome since 1988. So what is actually different? How this CKM syndrome is different from the traditional metabolic syndrome? We will request all the panelists to be very brief, because we'll be finishing by 20 minutes.
Yes, I think the important factor is that with metabolic syndrome, we are only looking at the risk factor clustering with regards to abdominal obesity, dyslipidemia, hypertension, and central obesity as the core principle. Whereas with CKM, we go beyond. We look into the cardiovascular factors, we look into the cardiovascular disease, as well as both subclinical, as well as overt, and its complications, as well as kidney disease, which are very closely interlinked.
Okay, thank you very much. So we'll continue with the same panelists, because we are lacking in time. So how common is CKM syndrome in our country, in India?
This is more common because here we have a huge prevalence of central obesity, which is a driver of the complications, and nearly 80 to 90% of our population will have the stage 1 disease, that is obesity or central obesity, and nearly 10 to 15% will have even cardiovascular disease. About in diabetes population, it will be about 30%.
Very, common, because this dysfunctional adiposity is very common in our part. We are sarcopenic and we are having this lot of adiposity there. So what are the major adverse outcomes associated with the CKM syndrome? Where should be concerned about CKM syndrome?
Well, one is the cardiovascular aspect, that is MI, stroke, cardiovascular death, and overall mortality. The second is the renal aspect, including ESRD and renal death. And now also, as Professor DeFronzo just mentioned, we also have actually CKML or CKLM, because we also have the liver disease, which is also significantly affected, and liver-related mortality.
Thank you. So what can be, can there be any improvement or regression of the stages? Because we all know that CKM stages are planned according to this, whether there is any risk, whether there is any subclinical condition, whether there is an overt disease, or whether it's just the adiposity without any risk. So is there any, if you take care very early, then can there be a regression of the stages?
So I think the most important aspect is lifestyle modification. Even early on, we can have a primordial or even primary prevention or secondary prevention by reduction of weight. And weight reduction per se can reduce all the risk factors: cardiovascular disease, and also renal disease, as again Dr. DeFronzo just mentioned, that weight also has a separate contribution to liver and kidney as well.
So, as Professor DeFronzo has already highlighted, that the central part is the adiposity, dysfunctional adiposity, and the insulin resistance. So, what is your comment? What is the role of this adiposity and insulin resistance in this, CKM syndrome?
So again, if we look at the adiposity per se, it drives the insulin resistance, one of the important pathways, dyslipidemia, hypertension, which are again driven by the sympathetic sympathetic stimulation as well as systemic inflammation as well. All these are actually triggered by obesity pandemic, which is currently going on.
So as we can see that all these three things are in a single string, and this string is actually this SGLT2 molecule. For this evening, it is this empagliflozin, this Empatrol. So what are the overarching management priorities across this CKM syndrome? How we should approach to this problem?
One is the primary prevention, that is weight loss, lifestyle, along with early targeting of the risk factors, whether it is glycemic control, lipid, and as well as hypertension, use of AC inhibitors, statins, and at later stages, it is specifically using the disease-modifying agents like the SGLT2 inhibitors, which nowadays several guidelines advocate as primary modality of treatment. Along with that, the GLP-1. And with regards to cardiovascular risk reduction, we have the statins, we have the AC inhibitors, ARBs, we also have the finerenone for the renal aspect. So
that is actually my next question. What are the classes of drugs which are particularly important to address these combos, these cardio, renal, liver, adiposity, and the blood sugar as well?
Yes, again, if we look at these, we now have the pillars, and almost I would say that most of the diseases, whether it is heart failure or CKD, or even probably now evolving liver disease, we have pillars. And here SGLT2 and GLP-1 are actually twin pillars. In cardiovascular disease as well as renal disease, we also have the AC inhibitors. And we also have the finerenone, which is also there, as well as in heart failure as well as CKD.
Okay, thank you very much, Dr. Professor De Malvio Sanal. I will now come to this Captain K, Dr. Jayanto Dotto. So how will you place this kidney problem in the whole this CKM spectrum?
Okay, so if you consider the mortality and morbidity from the patient perspective, you see that also from the financial angle, kidney problem is very much financially distressing for the patient. If the patient goes on dialysis, so it is very troublesome for the patient and patient family. So the primary prevention or secondary prevention for the progression of the disease to the advanced stage is very, very important. So I think prevention of the kidney disease is very in the early stage is very, very important as far as the CKM spectrum is concerned.
Thank you. We now see that the huge increase in these CKD patients as like these fatty muscles, fatty liver, fatty heart, this fatty kidney. And should we manage this CKD be organ specific or in the CKM syndrome, or should it be done holistically along with all these? So drug molecule selection, etc. How should it be?
As we know that the basic pathophysiology is all the same, be it endocrine, kidney or heart. It is basically the pathophysiology is same, so that the entity should be encountered or treated holistically rather than is a nephrological problem or cardiological problem or endocrinological problem. I think it should be done holistically, and basically the onus lies on the primary care level of physician, because we nephrologist or cardiologist, we see the patient in the advanced stage when the patient are going for the dialysis or the patient needs any intervention. So the endocrinologist and the primary care level physicians, they are the cornerstone of the prevention on the detection of the CKM in the early stage and the progression of the disease in the advanced stage.
Very nice. But as we have these molecules which can act together on many organs, that can be selected earlier in the course of this management. But as a nephrologist, how do you actually plan to fight with this tsunami of this CKD number, particularly this tsunami of this CKD syndrome, CKM syndrome?
So basically, it is the first of the lifestyle modification and the good control of the diabetes. Whatever molecule you have to control your HbA1c level, your blood pressure, what the class of the agent you have to target this 120/80. And the next is we have the 4 pillars now. As far as the CKM is concerned, one is ACRB, that is for our college life, we have only the AC and ARB. Now we have finerenone, now we have GLP-1 analog, and now we have this glyphosine, dapagliflozin or empagliflozin. So we have basically 4 pillars which can help us to prevent this tsunami of the Sikkim syndrome.
Thank you very much. We'll have to stage it well with this JFR and the albuminuria as well. So what are the strategies we have to slow this disease progression, which is actually the central holy grail of this evening today, the disease progression, how will you slow down this in the CKM syndrome?
Okay, so I have already mentioned these 4 classes of the drug, and there are in the pipeline, there are a lot of drugs. Basically, this CKD, this interstitial fibrosis under the tubular is very important component, and now the molecules are coming, this anti-fibrotic aldosterone antagonist and the endothelin antagonist is coming up, which can help us for further progression of the CKD. And I think the baseline is that you have to control blood pressure and your control blood sugar very well. That is the bottom line.
Holistically. So what are the socioeconomic impact of the CKM syndrome in our country? Because we all know the one the person goes into the stage of CKD or end stage, this family is drained down.
Yes, in India, we are a resource poor country. And we all know that the percentage of the CKD or prevalence of CKD is around 15%. In the US, it is around 18 to 20%. So for India, if we cannot prevent this tsunami or prevent this epidemic, it is a silent epidemic. We all know that in the early stage of CKD, there is no symptoms, so it is a silent epidemic. So if we cannot control in the early stage or cannot prevent it primarily, no infrastructure, no financial support, cannot deliver or cannot encounter this huge problem. So it's a huge socioeconomic problem. And this is also policymakers. We have to sit with the policymakers so that these molecules can be available in the cheaper, in the primary care physicians level. So I think that the prevention is the only answer to this problem.
Thank you very much, Dr. Datti, for enlightening us on this kidney part. Now we'll come to this Captain C, Professor Soumitra Kumar. We'll come to the cardio part later. It all starts with M, then the K, and then this heart, because all these patients actually die of these cardiovascular complications. So, Professor Kumar, why does metabolic disorders like diabetes and obesity predispose to increased cardiac events?
As such, they all lead to the risk factors. I mean, you have mentioned about diabetes, but diabetes and obesity and hypertension also go together, and so also dyslipidemia. So these risk factors go hand in hand. And besides that, the systemic inflammation plays a very strong role. So it is inflammation with the individual risk factors that lead to these increased cardiac events.
So it is all this adiposity in the heart, and that increases the insulin resistance, Sarah has highlighted. So how do we screen such patients for quantifying this cardiovascular risk? So we can reverse.
We have several clinical tools. Most of them are international. We are developing our own tools also. The LI ASCVD risk factors, tool score is there. We have the heart failure staging also. So we have biomarkers. We have very advanced echocardiogram. We have several other non-invasive markers to look at subclinical atherosclerosis. So it is not that there are no tools, but then one has to have a high index of suspicion and screen the patients individually.
So once this risk is identified and quantified, how to modify such risk to reduce the cardiac morbidity and mortality, which should be the target of us, to increase the longevity.
Again, going back, lifestyle modification comes first, and then we have to control the individual risk factors. And then we have several disease-modifying drugs. And what have not been mentioned are lipid controls. That plays an immense role. We have several agents beyond statins. We have to use them. We have to use antiplatelet drugs wherever they are applicable. And I'm not going to mention about GLP and SGLT2. They have been spoken. So I just added to the list.
So actually, we need evidence. So what evidence do we have from the recent trials in favor of these recommendations that use this SGLT2 or this molecule with the preference of one molecule over the other? Is there any recommendation for evidence in these recent trials?
Of course, Professor DeFronzo has spoken in details about Empatrol trial. So that was the blockbuster, pioneering trial that we had. Then we have had a trial from other glyphosines also, but not as robust and as empagliflozin in secondary prevention. We have robust evidence of ASCVD prevention from the GLP-1 agonists, the semaglutide in particular, the SUSTAIN 6 trial, and from the oral semaglutide also, the SOUL trial. So it's not that in the heart failure segment, we have several trials, DAPA heart failure, we have the Emperor preserved and Emperor reduced trials. We have also again from semaglutide, we have the STEP-HFpEF and other trials. And I will also mention that we are having increasing evidence from tirzepatide as well in the obese segment. So we have enough evidence from several trials. In fact, semaglutide has also shown benefits in peripheral arterial disease in the STRIDE trial in diabetic patients. So we have enough evidence now.
So in this, EMPAREG trial, this huge certificates was given to empagliflozin, but the first child of Professor DeFronzo was dapagliflozin. So I will ask the father figure at the end that why he just scored this empagliflozin over this dapagliflozin and other molecules. I will come to the end. So in the current diagnostic criteria of CKM is clear and satisfactory, or is there any scope of improvement? Whether you think that there is some other thing should be brought into this chapter, which has been discussed by Professor DeFronzo. Dr. Demalu, do you have any comment on this?
Yes, one is, if we have, as we discussed, the liver should be there. And that's why there should be a refinement as well as with regards to measuring obesity, especially in our population. It should not be BMI specific. It should be more of a adiposity specific, where we have to look into the body composition and especially with regards to role of central obesity.
Resistance, this adiposity should be there and the liver should be brought into this syndrome. Now, whether we have understood well that CKM syndrome approach of the staging is very important. So we'll be very short in this type because this, the stage 0 is very rare and stage 1 is only this dysfunctional adiposity is there. So whether we have understood very well, this 35-year-old male, BMI is increased 32, normal BP, normal lipids, HbA1c is within normal limits, eGFR is also in the standard limits and no albuminuria. G is normal, A is normal. So what is the CKM stage? Dr. Dotto, please.
There is a risk factor or adiposity without any organ involvement.
Okay, so when there is a risk factor, so 55-year-old female with type 2 diabetes mellitus, hypertension, eGFR has come down below 60, and this urinary albumin to creatinine ratio is more than 30, no known CVD, no normal ECG and echo, cardiovascular is not there, only kidney, just early part. So what is the staging
stage? CKM stage 2.
CKM stage 2, and we should address these risk factors.
Yeah.
Now this stage 3, this 60-year-old male with central adiposity, this type 2 diabetes, eGFR is 65, high coronary artery calcium score, elevated NT-proBNP, only these earlier changes, no symptoms or heart failure. What is the CKM stage? What is the implication? Professor Kumar.
Obviously, the next stage, stage 3. So we have, why would it be there are no symptoms, but then it may be, it is subclinical CVD.
Subclinical cardiovascular disease.
So we have to be very aggressive.
So another case, 68-year-old female with prior history of MI, but this reduced ejection fraction heart failure is there, overt disease is there, type 2 diabetes, and this CKD 3B. 3B means the GFR has come down to below this, in this 60 to 59 to 45 to 30 to 45. So in this case, so this CKM framing, this management, how we standardize this cardiology and the nephrology and beyond that, what should be our, priorities here?
This is a very difficult stage for us. When the kidney goes, it is very difficult for a cardiologist to manage the cardiovascular problem, but it is stage 4. So we have to work hand in hand with the nephrologist to save both the kidney and the heart. Any comments from Dr. Dotto?
Yeah, when it is basically going for the advanced stage of CKD, CKD stage 3B, from there the other symptoms like development of anemia is there. So to take care of the anemia correction, iron correction, all these things. Also the appearance of the hyperphosphatemia, that is the bone mineral disorders in the CKD appears from this stage. So apart from the delaying of the progression of the CKD, now we have to take care of the effect of the CKD on other organs.
Okay, thank you very much. And now we are not, as we have learned very well, and we have discussed almost all the chapters, we are not particularly going to when to refer to endocrinologist or nephrologist or the cardiologist. I will come to this last part. What message should we give to our young adults about this CKM syndrome? Professor Kumar.
Yeah, first of all, we must educate our young adults. In fact, from the adolescent stage, this has been my advocacy. not to, to have a very good lifestyle, not to put on weight. Okay, so from the childhood itself, and when they embark on the adulthood, that would be the stage to first screen them for the risk factors. Okay, we should screen all the basic risk factors, blood sugar, blood pressure, the lipids, at least when they pass out of their school and enter college. That should be the first time they should have everything checked.
Okay. So now the last question, which I discussed well before, I will come to Professor DeFronzo, that in the Empatrol trial, you gave huge certificate to this empagliflozin, and your first child was dapagliflozin. So you have given more of your love to your younger child than this elder child. Please, why EMPA scores above these other molecules? What is your comment?
Yeah. So this is the question the pharmaceutical company who invites you here hates to be answered. And the answer is pretty simple. All of these SGLT2 inhibitors, in my opinion, are virtually identical. And when I see patients, they're all going to be on an SGLT2 inhibitor. When I sign the patient out, I just put SGLT2 inhibitor, and whichever SGLT2 inhibitor the insurance covers, that's what the ward clerk will prescribe. And the same thing for GLP-1 receptor agonist. Cost is really, these drugs are all great. Cost is the major determinant. So if the insurance doesn't cover it, you write the prescription, no drug. So the most critical thing, in my opinion, is make sure the patient can afford the drug. But they're all very good drugs. I don't distinguish between.
Thank you, sir. That is the beauty of hearing from the, father of this molecule, because it is the horse's mouth, and we learned that all three molecules are same, but EMPA got this, advantage in this EMPA reg trial because the trial focused on that. So now this session is over from our side. Now we have very few questions to our panelists or this, father of this session today, Professor DeFronzo. You can ask small questions, one or two, before we, finish, and we have this, vote of thanks from our, organizers, Aristo Pharmaceuticals. I have to mic দিয়ে দাও.
Hello. Sir, is there any legacy effect of SGLT2? Because many of our patients start this medicine, but after sometime, say 1 or 2 years, due to side effect, they get rid of this medicine and they do not want to introduce it anymore. So if I use this for 2 years, is there any legacy effect?
The answer to that is there's no definitive study, because this is not the kind of study you would do. Once you're on the drug, you should be on the drug for the rest of your life. So if you have a reduction in GFR and you have albuminuria, you have intrinsic kidney disease. It isn't going to go away. So you should never stop the drug. If for some reason the patient stopped taking the drug and they come back to see you, you should put the person back on the drug. But I need to just emphasize what several of the people said. There are 4 pillars. They should not be on one drug. They need to be on an ACE and ARB at maximum dose. If you don't put the person on maximum dose, you're losing a lot of the benefit. Number 2, they should be on an SGLT2 inhibitor. In the United States, those drugs are relatively affordable. Feninerone, I add in all my patients. That's expensive, so the insurance has to cover it. In my opinion, they should all be on a GLP-1 receptor agonist. And the one pillar that I think did not get enough attention, all these people should be on a diuretic as well. It's very difficult to control the blood pressure, in my opinion, unless they're also on a diuretic. And elevated blood pressure is catastrophic for the kidney.
So we must not forget that this is a national program, and all these national moderators are also with us in online. So is there any question from the national moderators? Dr. Fatale?
Hello. Yes, I have one question here from Aurangabad. A patient with, we discuss about role of empagliflozin in various status of heart failure. So what's about atrial fibrillation? What I observed strangely, patients with atrial fibrillation and diabetes who are around these SGLT2 inhibitors, the rate is much better controlled, or there is less recurrence as compared to those patients who are not on this anti-diabetic medication on these SGLT2 inhibitors?
I'm not sure I understand the question, but obviously atrial fibrillation is very common in these people. And to the extent you can decrease the afterload and the preload, that takes stress off of the heart. And this may help you in cardioversion. And clearly it's better to have the people with normal sinus rhythm than to be in atrial fibrillation. But the SGLT2 inhibitors, to my knowledge, don't have any direct effect to improve the atrial fibrillation. Indirectly, by some of the benefits that I just told you about, by unloading the heart, that can help you to convert the people back to normal sinus rhythm. But I'm not, with the cardiologist can answer as well. I'm not aware of any specific direct effect. There are no SGLT2 inhibitors in the myocardium.
Thank you, sir.
Sir,
So,
I have a question.
last but one question.
I have a question to Dr. DeFronzo. Nowadays, obesity, liver disease, and cardiovascular disease very common in children and young adolescents. So, do you have any data about these children that we can use this SGLT2 inhibitor?
Yeah. So in the United States, we have an epidemic of adolescent obesity, and these kids are very, very difficult to treat. And in fact, in the look ahead in the RISE study, these kids are now in their early 20s, and many of them are having myocardial infarction and CKD. These drugs are very effective in these kids as well as in the adult population. And in terms of glycemic control, the only class of drugs that's really shown to work are the GLP-1 receptor agonists. It's very difficult to control glucose with run-of-the-mill. One of the things that really has not been emphasized tonight is the important role of pioglitazone. And in children, even though this drug may cause weight gain if you're using it as monotherapy, it's also very effective in controlling the glucose. It's cardioprotective, and since you're going to be using it with a GLP-1 receptor agonist, you're not going to be seeing weight gain. But management of diabetes type 2 is very difficult in children and adolescents.
Thank you, sir.
So,
Dr.
any
Ghosh.
question from the Chennai Center?
Dr. Ghosh from Samajinagar.
Yes, we can hear you.
Yeah. The very nice discussion and the way of its going up insulin resistance and various effects. Recently, there has been shown to be an CKM and the cancer relation. Can you throw some light on it?
Dr.
Fatale, can you please repeat once more?
Why don't you repeat?
Recently, in a circulation 2026, there is a relation between CKM staging and the cancer oncogenic relation.
Oh,
Can you throw some light on it?
between CKD and cancer.
Malignancy.
I'm not aware of such a relationship, but in obesity, of course, it's an incredible relationship. There are many cancers now that we're now aware of that are closely associated with obesity, and insulin resistance, hyperinsulinemia, and increased growth factors are one of the factors that clearly is playing a role in this association. But the CKD, I don't know, one of the nephrologists may want to comment. I'm not aware of a specific relation with the CKD per se. The key thing about CKD is that even though you have chronic kidney disease, you're 5 times more likely to die of a myocardial infarction. So if you have CKD, you need to pay critical attention to all the cardiovascular risk factors as well. But cancer screening, I think you wouldn't do anything that you wouldn't do in general practice.
Dr. MC Deepak from Chennai, do you have any question?
Yes, sir. There's a question from the audience who asks that what is the role of SGLT2 inhibitors in type 1 diabetes in a subject with proteinuria and heart failure?
Yeah, so as I said, SGLT2 inhibitors in the EMPA-REG outcome study, they had type 1 diabetic patients. So if you have a type 1 diabetic patient, you can use the drug. But if you have a diabetic patient who doesn't have doesn't have kidney disease, and you just want to use the SGLT2 one SGLT2 inhibitor. You can use it, but it's up to your discretion. It's not a drug that's officially approved by the Food and Drug Administration. I personally think that this is a shame. I use these drugs in type 1 patients. They're very, very effective. And we've actually published several studies on this. If you want to prevent euglycemic DKA, you just put the person on pioglitazone. Dr. Abdelghani, these papers are all published in Diabetes, Diabetes Care, Diabetologia. Pioglitazone drops the FFA level to a very low level. So that's the precursor of ketones. So once you're on the pioglitazone, I won't say never, but I would say 99% chance you'll never develop ketoacidosis. And in fact, we have a big study that's going on to look at this in type 1 diabetic patients right now.
So last question, I will invite Dr. Esar Khan from Gorakhpur, is the moderator, the renowned nephrologist there. So Dr. Khan, do you have any question on this CKM syndrome related to nephrology particularly? Dr. Khan, please.
It looks like his mic is not working.
Regarding this session. Hello, sir, side. Hello. Am I audible?
Yes, we can hear you.
It's a very informative and very nice session. And phlogens are like a major breakthrough in modern nephrology. So my question is, it is to Dr. DeFronzo, that what is your personal experience and how oftenly you stop SGLT2 inhibitors in your patients?
Very good evening, doctor. 1 minute. I request Dr. Arnachan sir to.
Again, I'm not sure I understand the. What is the question? What is the question?
Dr. Khan, we cannot hear you properly. Can you please repeat the question once more?
The question is, like you have started a patient on SGLT2 inhibitors, and how oftenly, and the patient is on follow-up with you, how often you stop SGLT2 inhibitors, and what are your reasons mainly?
Okay, so how often do you follow up the patients? Well, that, of course.
What are the reasons?
In my opinion, you're never going to stop the SGLT2 inhibitor. In fact, in all of the big renal studies, the people who got into the studies, there's usually a lower level of GFR. It's around 20 or 25. But there have been now follow-up analyses, both from EMPA and dapagliflozin, that even in people who have GFRs less than 20, you're getting benefit. And in my opinion, you should be on the SGLT2 inhibitor until you walk into the dialysis unit. And there also are studies going on in people who are on dialysis. Obviously, you're not going to get renal protection, but you may get still cardiovascular protection. So this is not proven, but there are ongoing studies to look at protection against heart failure. But you should never stop these drugs. Maybe if you keep having recurrent, the other point I want to make is these drugs do not cause bacterial infections. What you get are mycotic infections. In all the big studies, none of the studies have shown any.
One comment and one question. This drug is so beneficial that now it is approved for use in the non-diabetic kidney disease. We are now using in IgA nephropathy and FSGS also. Yeah. And the second question to Professor DeFronzo, that you have said that SGLT2 inhibitor is responsible for the 90% of the sodium glucose absorption in the PCT and 10% by SGLT1 distally. So if prolonged use, is there any chance of upregulation of the SGLT2 receptor and the decrease of the efficacy of this molecule on the long-term use, and how to deal with that problem?
Yeah, so we published all that data 15 years ago. So I didn't tell you, but there's also an upregulation of SGLT1. The problem is the people have tried to develop the SGLT2 and SGLT1 inhibitor, and what happens is you get more glucoseuria. But now, because the glucose in the plasma goes down, that offsets. So a net result in terms of glycemic control, there's no benefit in terms of reducing the A1C And none of the studies with the SGLT2, SGLT1 inhibitors have actually looked at either cardiovascular protection or renal protection. So those drugs really, they actually are approved in Japan, and we have one in the US, but I have to say it's not very popular. It's not used very much. And as you pointed out, and I stated, I think in the Empatrol outcome study, they had type 1 patients, type 2 patients with other causes of renal disease. So it should be, these drugs should be used in anybody with renal disease. The only group that has not been studied is people with polycystic kidney disease. Strange reasons why they didn't include those patients. But if I had someone with polycystic kidney disease, I would probably be treating them with the drug as well, although they were not included in any of the studies. Yeah.
So every good thing must come to an end, and every word is insufficient to thank this living legend in the world, Professor DeFronzo, who has traveled to India to enlighten us on this thing. So, sir, thank you very much from the core of our heart. We must, thank you. A big applause for Professor DeFronzo and all the panelists here. Captain C, Captain K, and Captain M. Altogether, they have enlightened us in a very short. Their wisdom has been shared with us. I must thank all the doyens practicing in this city who have joined in this beautiful evening. We have enjoyed together the day, which is important culturally, politically, and scientifically. We are enriched enormously scientific point of view, and we must not be less in thanking the people who have organized this program, these Aristo Pharmaceuticals, who brings this Empatrol with this combination with Empatrol L and Empatrol S, almost all combinations, and this trio combination, as highlighted by Professor DeFronzo, with metformin as well. So,
in my opinion,
thank you, Dr. Sanjay Banerjee sir, Devasis Bosu sir, and almost all these national doyens in the company Aristo Pharmaceuticals. So we come to the end, and we'll request all the panelists and sir to come for a group photograph.
Okay, but heart failure with preserved ejection fraction, I think pioglitazone probably